Hello, I'm Dr. Wanda Torres, MD. I am the founder of Suncoast Women's Care, a medical facility renowned for our expertise in women's reproductive health, obstetrics, minimally invasive surgery, and robotic assisted surgery. Join me each week as I interview guests in the top of their fields about the world of OBGYN, exploring the innovations and personal stories that shape our medical experiences. Hello, everyone. I'm Dr. Wanda Torres from Suncoast Women's Care. And today, continuing the conversations with physicians. And today, our guest is Dr. Camila Malinowska. So, welcome, Dr. Malinowska.
Thank you for having me.
Of course. So, Dr. Malinowska, where did you come from?
So, I immigrated from Poland. I
Yeah.
was born in Warsaw, and then I grew up in New York City. Then I left, and I've lived kind of all over the United States, so I never know how to answer that. I most recently lived in Detroit, which was Detroit, and I decided I don't like cold because I'm an angry little monster when it's cold. So now I live in Florida, and it's amazing.
I understand that. So, tell me a little bit about your education. I know you grew up in Poland and migrated to New York City. I know you did your schooling there, then you went to med school, then you did your residency in Detroit. So, tell us a little bit about that.
So I did college in Pennsylvania. I initially was an exercise science coaching and nutrition minor, and then midway decided to become a doctor. So I switched majors and graduated with a neuroscience degree. In my heart, that I am will always be an exercise science sports med person. And I went away to med school in Kentucky. So I went further and further away from society into the mountains. And once I graduated medical school, I did residency in Detroit.
Okay. So, one thing that I want to share with our patients is that Dr. Malinowska is an ice skater. And she did this competitively, and she still trains.
Yes. So I learned how to skate by accident. You're totally putting me on the spot. I learned how to skate by accident. And then I trained in New York City. I trained under a coach and passed my testing, competed at the adult U.S. Figure Skating Nationals in 2021. And I'm taking a little bit break right now. But skating is actually the reason I became a doctor because I fractured my feet in 3 places. And that was around the time in college where I switched majors.
Okay.
So I have my nice little tattoo. That's my figure skate. It's the big reason that I ended up going into medicine.
Fabulous. So, another thing is, when did you decide to do OBGYN? We all do our rotations as med students, and when did you decide to do this?
So I decided to go to medical school because I wanted to do orthopedics, which is hilarious.
That makes sense because you fractured your foot. Yeah.
Yeah. And my first rotation in 3rd year was OB, and I loved it. It was like a small community hospital. We didn't have residents, and I was like, oh my God, this is the coolest thing ever. And I kind of sat there and was like, okay, I really like this. I also kind of like general surgery, emergency medicine, because I think when you choose this career, there's a lot of adrenaline, making a lot of really fast-paced decisions. But I also really like the continuity of care. And I realized too from my own experiences, I had really bad cycles. I have PCOS, and so I already kind of knew a lot of stuff that I didn't just really put together until I started doing this job. So I kind of figured out I didn't want to do emergency medicine. I didn't want to do general surgery, and decided to do OB. So I really, really, really love it. And I love it for that continuity. And I also think we have a very unique relationship with patients,
Definitely.
which I think is just so cool.
In my opinion, it's the most complete specialty out there. Because we can treat our young patients from pediatric age follow them throughout their reproductive lifetime and, as we start aging into the menopausal years. Uh, Hence, I'm talking about myself. My youngest patient during my years of practice was 10 years old, and my oldest patient was 96-year-old, and everything in between. So we can do deliveries, we can do surgeries, we can take care of the patients in the office and do continuity of care. So that's, I think, what attracts a lot of us to this specialty.
I think there's a, I even today I had a few patients who were just tearful. They were going through some stuff and, they're apologizing because they're crying.
Hmm.
And one of the things that I tell patients all the time is, you come here and this is very different from I think other medical specialties. Um, in the sense that there's a vulnerability. There are these questions about femininity. I am having a hard time carrying a baby, or I've had multiple miscarriages, or I'm having issues with my own sexuality, or I'm having relationship issues with my spouse, or I'm going through these fundamental changes of menopause. And I don't think you have that vulnerability and that relationship with patients in other specialties. Like, I just don't see you going to like your cardiologist and being like, "Oh my God, this is my third miscarriage." Like, I feel like
I completely
just
agree.
very different, and that's okay. There's space. Different specialties do different things. But my husband is a general surgeon, and one of the things that he tells me all the time is the depth of relationship that we have with our patients is so inherently different than the relationship that exists in other specialties. And I truly think that is a gift because there's a vulnerability in that I think sometimes gets lost in just standard like Western medical care.
Agree. So now one of Dr. Camilla's hobbies is shelling. She loves shells.
So,
You can find her at any beach collecting
I
shells.
mean, literally, yes, I have very obscure hobbies. So, I am a nerd, and
There's nothing wrong with that.
no,
We are
it's
all
just
nerds.
people are like, I like shells, and I'm like, no, but like I like this subspecies of shells that it's only found in like the Philippines on this one island, right? Okay, like most people are normal, and then there's me. So, I collect and restore shells, and I do crafts, which is a lot of fun for me in my spare time.
Mhm.
So my house is a treasure trove of shells.
Personally have seen it.
So I do that. I have huge clamshells that are about this big that are fossilized. I also go on fossil digs here in Florida. I go to 10,000 Islands, to these uninhabited islands in the Gulf where you get to do those things. And one, really experience Florida. And, but also I say, find the dudes. You find the shell dudes.
I know.
So there's that. And then my love of plants, which is forever.
I know. Well, thank you, Dr. Camilla Malinowska, for sharing some of your hobbies and passions with our patients. And you can meet her at our office at Sonko's Women's Care. So, the topic of today is contraception. So, some of our patients ask us, the pros and cons of contraceptive methods and how to choose them. So, how do you counsel our patients?
So, I think this is a very broad topic, but
It is.
the first thing that I typically talk to patients about is one, what have you been on any form of contraceptive method? What have you seen or heard about these methods? And sometimes kind of starting there. But the other aspect of that is talking to patients and saying, what does contraception look for you? How is your life like? Can you remember to take something every day? Do you um, want to come in, for example, every 3 months for a form of birth control? Do you want something that's longer acting? Or are you seeking a method of permanent contraception? And so that's typically where I start off with, because that'll kind of help you narrow things down or also address if patients have had poor experiences with birth control and also addressing that within the bigger context of just talking to them in counseling.
And of course, we always review their history if they have medical problems. So, for example, if the patient is past the age of 35, has high blood pressure, is a smoker, it's completely different than a younger patient. So, how do you counsel those two different types of patients?
So, in terms of one, we talk about what are their underlying risk factors. So, for patients who have had a heart attack or a stroke or a blood clot in the legs or lungs, or for example, tobacco use, so I'll go back to that one, or migraines with aura or liver disease, or for example, even patients with breast cancer. Those patients are going to be ones where you really need to be careful in terms of selecting the kind of birth control for them. Specifically, with patients who are over 35 who are smoking tobacco, they're at a much higher risk of things like a blood clot in the legs or lungs. And so we typically stay away from birth control methods that have estrogen in them. And so your alternatives to estrogen containing contraceptives are things like progestin only pills. Most women are familiar with them in terms of they're the um, breastfeeding birth control pill.
Mhm.
And we do have different forms of that now that are a bit more effective than it's mini pill is what it's called. We have things like Depo, which is known as the shot. We do have the implant, which is good for 3 years. And then you have your IUDs that are progestin only.
Mhm.
Alternatively, if you have a patient who really doesn't want to be on any kind of hormonal therapy, then we talk about things like a copper IUD, or we talk about contraceptive gels such as, oh, I am totally blanking on Phexi,
Mhm.
PHEXXI.
Mhm.
And so we kind of talk about those things versus also talking to them about things like barrier methods.
Mhm.
So that's where we kind of start.
Okay. So, you're mentioning a lot of the what we call the LARC methods, the long-active, reversible contraceptives. What are the pros of those?
So the LARC methods are your when we talk about more efficacious methods of contraception, why it's more of the if you set it and forget it, to date myself. Um, why you come into the office, we place this form of contraception, whether it's the implant that goes under the skin in the arm, or your IUDs. Now, modern day contraceptives are incredibly effective. You're looking at anything over 91%, really starting at 93% for your birth control pills. Then you kind of slowly increase efficacy in terms of things like Depo, which is every 3 months. But your most effective methods are your LARCs. So you're kind of looking at the range of 99% effectiveness,
Mhm.
which is typical to how effective a sterilization procedure is.
Perfect. So, sometimes we have our teenagers come with their moms, and they're very, very concerned about inserting an IUD. Um, because in the past, the IUDs used to cause issues with infertility. Do we have those concerns that nowadays? How do we counsel our teenagers?
So, way back when, and I don't remember exactly where this comes from, but the thought process was that we don't provide IUDs for women who have not had babies. And that's really not indicated anymore. It's ultimately just a conversation of who is a candidate, anyone who you've counseled. Okay. Obviously, if they don't have a uterus, then they're not getting an IUD. But so when it comes to inserting an IUD, we're not concerned about potential concerns with fertility. I think a lot of the bigger concerns are discomfort and pain with insertion.
Mhm.
And I think that needs to be tailored based on the patient. So I always talk to patients about what is this going to feel like? One, also, some patients in general don't like coming to the gynecologist. So it's not a great experience for them. And that's when we talk about, how are pelvic exams? How are your periods?
Mhm.
Um, what is the perception of cramping for you individually? Because it's going to also affect your individual perception of pain, especially with pain with insertion. So, things that I specifically counsel patients on are things like numbing the cervix, um, adding potentially pain medicine an hour beforehand, medicine for anxiety. I do have some patients that have really bad pelvic pain or they have pelvic floor issues. And in those patients, if they're very concerned, then we actually do give them laughing gas or nitrous oxide in the office to help.
Mhm.
So, there's a lot of different ways to kind of tailor that experience for patients that just becomes a conversation between us and, what do you think would be best for you?
Hmm.
The other thing too, especially for adolescent patients who likely have not had a pregnancy or baby before, talking to them about giving them medicine the night before to help open or dilate the cervix. That can really help too. Um, I think a lot of the discomfort is really going through the cervix during insertion. It can really cause like an intense period cramp.
And sometimes besides, giving them the medication to open the cervix a little bit, we can also insert while the patients are on their menstrual cycle, so it makes it a little bit easier for the insertion. Going back to other alternative and options, we have the birth control pills, of course, which you have mentioned a little bit, the combination oral contraceptives and the progesterone only pills. But we all there have other alternatives like the NuvaRing, like the patches. So tell us a little bit about that.
When I kind of counsel patients, usually I talk to them about the pills. But then the next thing I talk about is, so if you don't want to take something every day, then we talk about, do you want to take something every 3 weeks, which is
Hmm.
really where you start talking about your NuvaRing. So NuvaRing is a combined form of contraception. There is estrogen and progesterone in it. You essentially place it inside the vagina. It's similar to patients who use tampons or things like a Diva cup. If it's placed correctly, you're not going to feel it or be cognizant of it. So, some patients might not necessarily want to place something inside the
Hmm.
vagina. I do go through the insertion instructions with them and kind of like the cheat code for helping put one in if they're concerned. So we talk about that. And the other thing that you can do with that form of contraception in the same way that you can with things like the patch or your pills is skipping their cycles if they just want to be on a continuous form of contraception. Other thing that I typically clarify is that the period that we have on birth control is not really a period. It's really just a withdrawal response to not having the contraception. And so I tell patients it is safe for you to not have a period because it's not really a period. Whereas if you're not on hormones, then yes, you do actually need to have a
Hmm.
period. Um, Once we talk about that, then we go from every 3 weeks. One that I realized I skipped is things like the patch. So patch is similar in the sense that it's you're going to be placing it weekly, so it's less often than the ring. The big one with this is we make sure so patients whose BMI is greater than 30, we can't offer it to them because it can decrease its effectiveness. I think bigger concern here in Florida is people being sweaty. It is a million degrees here. So we kind of talk about that. But in terms of also like a discrete form of contraception, you can still consider that to be a discrete form in the same way the ring can be. And that's also an important aspect of having discretion for patients if they
Hmm.
don't want anyone else knowing that they're on a form of contraception. Once we move past vaginal ring, then I talk to them about Depo. So Depo is the shot. So Depo, we have patients come in every 3 months in the office. Most patients are aware of Depo. I feel like it's not more famous, but it's just more well known versus things like the ring.
Hmm.
And you do have to come into the office to get it injected. And in terms of any kind of contraception, you can have the 3 to 6 months of bleeding with it. And so I also talk to patients about that because the bleeding can be a little bit irregular, more so I feel like with Depo, but that's my personal perception, I guess, as a physician.
Right. We always educate our patient about side effects from the different methods. So, one that patients always ask about, am I going to gain weight with the contraceptive method of their choice? So, tell us a little bit about that.
So the one that's notorious, or I guess is the most famous one for that, is Depo. But if you actually look at the studies about Depo, it's really when they've done these longitudinal studies, they're seeing that patients will gain up like 10 pounds in a year, which is not necessarily significant.
Mm-hmm.
I tell patients that whenever you're on a hormonal therapy, you can have any array of side effects. So what that means is a contraceptive method that may work for me may not work for you.
Right.
And in general, most contraceptives that we have now are very, very different than the ones that initially came out in the 50s and 60s. They're really considered more low dose. They're better tolerated. And for the most part, especially with patients who have had side effects, I really talk to them about what side effects did you have? What were you on? How long were you on it for? Because especially with combined contraceptives, I think a lot of the side effects are based on a function of the specific kind of estrogen that was in what they were on and the specific kind of progesterone, because that's going to kind of dictate some of the side effects. So I have that conversation with patients and also saying, one, birth control, not all birth controls are created equal. They're just not.
Right.
And having an issue with one does not equate to having an issue with all. And sometimes it's being patient, kind of writing it out a little bit. And also what we're tailoring it to in terms of, is this someone who has really, really wicked periods? Is this someone who is perimenopausal but maybe doesn't want to be on a higher dose of birth control? Is this someone with endometriosis pain or maybe even acne? There are certain kinds of birth control that are more formulated towards those things, and they're not all the same.
Okay. So, going to the IUDs, you mentioned before that there's different types of IUDs. So, how do you counsel the patients how to choose between them? There's the copper IUD versus the uh, progesterone IUD. So, how do you choose?
So I think it depends on individually what the patient wants, how long they want the contraceptive method for, past experiences. In general, the big thing that I always ask is one, how's your period now?
Hmm.
If your period is very heavy or very painful, I will counsel patients that copper IUD is more likely to exacerbate that. Have the studies necessarily proven that? No. This is more of a clinical experience thing where I say if you're really, really heavily bleeding during your periods, the copper IUD it's not going to improve that. It might make it worse or just keep it the same. Your copper IUD is good for 10 years. So that other part of this is how long do you want this method for? I also ask patients, do you want a period or not? If you're someone who has historically really bad periods, you might just say, I really don't, I don't want it. I don't want it. So then I talk to them about your progesterone IUDs. And so I start with, if you do not want a period, the device that is likely to give you that is your Mirena IUD.
Hmm.
So Mirena in general has your FDA approval for heavy bleeding because of fibroids. It also actually is indicated for things like endometrial hyperplasia, which is when you have an overgrowth of the lining in patients who are potentially perimenopausal or menopausal, because it decreases your risk of endometrial cancer, which in general, your contraceptive methods that are hormonal do. But so your Mirena IUD, 30% of patients won't get a period.
Hmm.
Uh, I think in practice, I feel like I have a lot more patients that don't have a period on it than the quoted data.
Hmm.
So I typically start there. And, if I have a patient who said, I don't really mind having my period, but like not having a period freaks me out. That's when I say, okay, then we talk about your Kylena,
Hmm.
your Skyla, or Liletta. So your kind of Skyla is your least amount of hormones, where in all likelihood you're going to have a cycle. It just might be very scant and very light. So that the Skyla is for 3 years, and they're really same hormone, just different concentration that's being released, and you can go from anywhere from 3 years to 5 years to 8 years. In general, I think the length of effectiveness for these devices is going to change because really the data is what we've studied them lengthwise in the US, whereas in Europe, they're actually indicated for longer time.
Right. Okay, so we mentioned the barrier methods, and are they effective?
They are if you use them every day.
Exactly.
So, when we talk about barrier methods, so one, going back to this, because I had this conversation this week, pulling out is not a form of birth control. So if we're going to use birth control, such as condoms, you have to use them every time.
Correct.
Okay. Other thing too is if you have a failure of a barrier contraceptive, is making sure you have access to things like Plan B.
Mm-hmm.
But really, when we talk about your barrier methods, is making sure they're not expired, making sure they're not sitting in your car and melting in the Florida sun, making sure you're not sitting on them, making sure you're using them correctly. So knowing how to use, for example, female or male condoms.
Correct. And now, one of the methods of contraception is permanent sterilization. And there's a lot of back and forth. Should we offer it to younger patients? Is there a cutoff? Do we need to talk about that?
So, I think that if we want to look at historical trends, especially within our profession, there's been a very paternalistic attitude about contraception, specifically sterilization. And so I am not of that mindset, which I mean, you already know.
Mhm.
But so for me, I talk to patients and take it on a case by case basis in terms of, if you're approaching me because you want a sterilization procedure, where is that coming from? Is it coming from a fear regarding potentially political climate? Is it fear from, what is your individual access? Do you live in a really rural area that doesn't have access to contraception?
Mhm.
Or is it, you want something where maybe your family members are maybe too much in your business and they don't need to be? And is it concern for, I don't ever want to be pregnant, I don't want to be put in that situation? There's, I think, a whole spectrum.
Mhm.
And also talking to patients about, have you been on anything else? Have you had a conversation potentially with your partner? And it's not about, for example, like whether or not the partner agrees. I'm just kind of gauging, where are we in this process of thinking about this? And have we asked other doctors? Have we potentially asked several doctors? And where are we in our reproductive lifespan? So how young are we? Do we have kids? Do we not have kids? I think all those things play a role. And so I really take it on a individual case by case basis. And I gauge, one, understanding how much research they've done. I have a lot of patients who find me because of we call it the list.
Mhm.
So I feel like patients who are specifically seeking sterilization care have done their research about what they want.
Right.
And I think fundamentally, as obstetricians, I tell all my patients, like, you have autonomy.
Mhm.
You're an adult. I cannot make decisions for you. And I also can't go to your house and make you take your birth control.
Mhm.
So it becomes a conversation of, here are your risks, here are your benefits, here's what this looks like. And I have that conversation, I think, to the point that they can vomit the words back out at me,
Mhm.
because I tell them, if I take your tubes, I don't take them to my house. I don't put them in a jar. There's no take backsies. You don't get them back.
Mhm.
So I want you to be 100% sure.
You're right.
Because especially for younger patients, you have that risk of regret. And that risk of regret can be anywhere from 2 to 26%, especially in younger patients. Um, and also, you're talking about, so not only age, but race and previous reproductive experiences.
Mhm.
So I think it's based on a whole bunch of factors, and especially now in the times that we live in.
The last topic that I want to talk about is can you explain to our patients how do you perform the sterilization?
So with a lot of patients who I feel like are now seeking out sterilization care,
Mhm.
a lot of them come to me and say, I don't want a tubal.
Mhm.
I want a bicep, which is just the hip
Mhm.
Gen Z term. So, one, there's been a shift too within our own profession of kind of coming away from doing things like fill sheet clips, which I never even saw one in my residency, tubal ligations, which I saw in my training during C-sections, and now towards really taking, I say, the whole tube and nothing but the
The
tube.
full length of the fallopian tube. Yeah.
Exactly. And so for me, I will always aim to do a salpingectomy, which is removing the full length of the tube, as long as it is safe for me to do so.
Mhm.
And so what does that mean? That means sometimes, for example, there might be a lot of scar tissue.
Mhm.
Whereas, if I'm going in and the aim is to perform a sterilization procedure,
Mhm.
my goal is to still do that. But if it's not safe for me to maybe take the whole tube on one side, I will at least do a partial salpingectomy. I'll do a ligation on the other side. So we at least have that.
And we do this laparoscopic.
When we do this procedure, it's through a minimally invasive technique. So typically it's 3 to 4 small incisions about this big. Procedure in and of itself is an outpatient procedure as long as everything is okay. You get to go home the same day.
Mhm.
Recovery, I'm big on harping about this. Really no heavy lifting, more than a gallon of milk for 6 weeks. Like, you can walk, you can go up and down the stairs, but really nothing more than that, because I don't want people developing a hernia after.
Correct.
So we look in with a camera, look around the entire pelvis. And for some of my patients too that are having this procedure, if they have chronic pelvic pain, things like that, I'm also looking for things like endometriosis.
Yes.
So the procedure is about an hour. You're probably in the hospital for half the day once we factor in getting there early, recovery, things like that. And total downtime or healing time is really 6 weeks.
And we always emphasize, it takes two to tango. So the males have to take some responsibility, and they also should be counseled about vasectomy.
Yes. So I definitely talk about this, particularly too with our pregnant patients, about, if you're having this discussion or you have a high risk pregnancy, has there been a conversation with your partner? And so why? The There are very big differences in terms of how we sterilize women and how we sterilize men. So for us, we're going to sleep under general anesthesia. If you are someone with a lot of high risk factors, so meaning you had a heart attack or a stroke or you have a bleeding disorder, there's an inherent big risk of you being put to sleep for this. Okay. Versus for the men, it's a in-office procedure where we're not even using scalpels. It's considered a bladeless vasectomy. And it's maybe taking 15 minutes to do that. They're home that day. They do get sent home with pain medication. And the big thing that I emphasize with patients about that is making sure that their partner goes for the follow-up, because this is where things get squirrely.
Right.
Because men historically have not had to be largely responsible for contraception. So, for us, we're like, okay, got to get my pills, got to get this, got to get birth control. Whereas I kind of explain the background, right? So if you get snipped, you get a vasectomy, they do need to come for a follow-up to make sure the swimmers don't swim anymore. Because I'm sure you have been there. We have had many patients come in pregnant after their partner got a vasectomy and they never came for their follow-up appointment.
Yeah.
And I don't want to see our patients on the news.
Okay, so I think we have covered the contraception topic extensively here, and I'm sure if there's any more questions, our patients can come in for consultation with any of our physicians or providers. Thank you, Dr. Camila Malinowska, for participating in the conversations with physicians at Suncoast Women's Care.
Of course. Thank you for
I will
having
see
me.
you again.
Absolutely.